Okay, we're on. And now to get our work done. Put a toddler right. So now at least I know how to use Restream. Okay, 1 hour work, let's go. I gotta finish my rest, but let's go. I will do farm today. Asthma, let's go. And I need the Australian guidelines for asthma. What better place than UTG? Either 36, maybe I put a timer as well. Eve is a 36-year-old woman who presents to the ED with tachycardia, tachypnea, hypertension. She's hemodynamically unstable, peripheral cyanosis, which indicates poor oxygenation, and silent chest, which is very severe because there's no compensation. And she has a past history of asthma. Midpoint was not effective, and the heart rate was 150, blood pressure is low, urinalysis is normal. My provisional diagnosis, given the past history of asthma, presence of silent chest and hemodynamic instability, would be that of a severe asthma attack, and I'm concerned about status epilepticus, given salbutamol was not effective. Other life threats that may cause the above respiratory symptoms include life-threatening causes such as pneumothorax, pulmonary embolus, pneumonia. I would also like to exclude other respiratory conditions such as COPD, for example, although the patient's age and lack of smoking history is not consistent with this. I'd like to also rule out sepsis due to other causes of shock due to hypertension, hemodynamic instability, whether it be a hypovolemic, cardiogenic, distributive, and I would like to also exclude anaphylaxis, which is a type of distributive shock. What are my priorities in the acute management of this case? In the acute setting, I would like to improve the patient's oxygenation, correct hemodynamic instability, and manage the underlying cause. So, I would first use a non-rebreather mask and oxygenate the patient at 15 liters per minute and I would then move to ensuring she obtains nebulized salbutamol at 100 micrograms, and this can be done through a spacer, where she'll be taking one spray of the salbutamol followed by 4 breaths in and out to absorb it orally. I would then proceed to other pharmacological therapy to manage the cause, and this could include using corticosteroids such as prednisone to reduce the inflammatory response. I may also like to use ipratropium bromide, which is a cholinergic medication that relaxes bronchial smooth muscle acting on muscarinic receptors. I would also consider magnesium sulfate, as this is severe asthma, and if the patient is refractive to these therapies, I would then proceed to intravenous salbutamol, and I could consider other medications such as aminophylline for the patient. How would you stabilize her blood pressure? This may be consistent with the picture of shock. Given the hypertension, tachycardia, I would conduct an ABCDE assessment of the patient given the severe critical condition, and I would ensure that airway is patent. I could then consider for circulation, I may like to place the patient at a cannula and run maintenance fluids and a bolus as well, just of normal saline. So that may be, say, 500 ml bolus of normal saline to correct any volume causes of shock. I would then look for signs of infection, and I would look for any evidence of distributive shock, anaphylaxis. If so, give epinephrine, and I could consider using presses to raise her blood pressure, such as noradrenaline. What are the clinical indications for ventilation? Clinically, if the patient is not able to maintain their airway, or there is a foreign body, or there is impaired oxygenation and low evidence of respiratory failure, such as type 1 or 2 respiratory failure. Type 1 being characterized by low oxygen, arterial oxygen, less than 60 millimeters of mercury, and type 2 being indicative of raised carbon dioxide with arterial levels greater than 50 millimeters of mercury. I could consider BiPAP, CPAP, positive pressure ventilation, and then consider intubation if needed. What investigations would you like to do? My diagnostic investigation for asthma is, of course, spirometry, lung function testing, looking at the forced vital capacity of the forced vital capacity, and also the fraction and the expiration over 1 second. And I'll be looking for an obstructive pattern that responds to pharmacological bronchodilation. I would bedside consider doing, in this patient, full blood glucose, given the hemodynamically unstable, full blood count, CRP, looking for signs of inflammation. EUCs, assess renal function given the patient's in shock. And imaging, I would proceed to a chest x-ray. And didn't go to chest x-ray. Anything else that I'd do? What are the triggers? Well, an asthma attack can be triggered by multiple factors, including non-modifiable, modifiable triggers. Non-modifiable triggers may include smoking, exercise. Non-modifiable may be seasonal, stress-related. Interpret these are two blood gases. So here we can see is acidosis, and it is due to respiratory causes, and it hasn't been compensated. There are some, and the base excess is normal. If it's high, it means there is an excess base. If it's low, it means there is a unknown acid, and oxygen saturation is low. So the arterial blood gases depict a biochemical picture of hypoxia with respiratory acidosis and no metabolic compensation. This may be consistent with the acute phase of an asthma attack. What are the long-term pharmacological therapy for asthma? Long-term therapy involves long-term pharmacological management of asthma depends on the severity of the asthma. So mild cases of asthma, which may not affect the patient's daily life and occur once a month, may be managed with a short-acting beta agonist, such as salbutamol. PRN is required based on stresses, and repeated attacks. Let's load battery, huh? We're all connected now. Okay. What is a long-term pharmacological therapy? Yep. Recurrent episodes of asthma more than once a month may be managed with prednisone and a short-acting beta agonist, and asthma that interferes with daily life may require a LABA, corticosteroid to reduce the inflammatory process associated with asthma, and other pharmacotherapy including leukotriene inhibitors such as montelukast, and zefirlukast, and more recently monoclonal antibodies. I have no clue what these monoclonal antibodies are. I'm butchering this station. Alright. Next question. What are the pathological changes you would see in asthma? Asthma is pathophysiologically characterized by airway hyperresponsiveness. So this is bronchoconstriction upon exposure to a stimuli, inflammatory process with exudate that decreases the luminal diameter and causes an obstructive pattern of respiratory disease, and mucus plugging, where there is a substantially increased production of mucus by goblet cells, which may further decrease the luminal diameter and prevent expiration of air from the respiratory tract. What else would I see? Don't know. This is such a bad answer. What medication can be taken for exercise-induced asthma? Saba? What else? We can use a Saba, you can use a Lava, you can use a... I think Saba, you can use ipratropium, possibly. I'm just making this up. And Montelukast, let's say. What drugs can you add for acute exacerbation? We can add mag. Isn't it just Laba, Saba, and then on top of the short-acting beta agonist and prednisone, we can also have leukotriene and antagonists, monoclonal antibodies, aminophylline, theophylline. You know, the usual. How would you monitor asthma? History taking, I would. Follow up. Upon follow-ups with the patient, I would consider the number of episodes they've had in the past month, the associated triggers for those episodes, the length of each asthma attack, whether she's requiring any ICU admissions, which could indicate that the asthma is poorly managed. On examination, I could look for evidence of poorly controlled asthma. There may be evidence of pectus carinatum in bowel chesting due to an obstructive respiratory disease being present. I don't know. Oh no. Let's do, what did I get wrong? Pretty much everything, I'm guessing. Let's see. There we go. ETG saved my life. So asthma. I should probably keep my Oh my god, the legend himself. The legend himself. Intrinsic, environmental, and drug categories. True. I forgot beta blockers. Oh, load. And then intrinsic, true. And Mercelin. Okay, now I need to get back to work. That's enough commenting. Thank you. Alright. Let's see what keys notes I've got. Asthma files. Shock, secondary to status asthmaticus, which is acute exacerbation, which is not responsible to initial bronchodilators. Given the asthma history, where does it say she had a recent OT? Different case. Silent chest, tachypnea, and tachycardia. Yep. Respiratory causes, tension pneumothorax. I missed foreign body. So why would I? So I'm considering life threats. So respiratory life threats include pneumothorax, pulmonary embolus, and also bacterial infective causes such as pneumonia. And silent chest, you should also consider foreign body, which I did not. Just a 36-year-old woman, right? So foreign body. We've mentioned COPD. Respiratory, I'm concerned about the cause of shock and mention anaphylaxis, but need to be more specific with shock. Shock is hypovolemic, cardiogenic, distributive, and obstructive, which I did not mention. It's 4 types of shocks, right? Pump failure, blockage, less fluid in the system, and the wrong pipes dilating. Okay, anaphylaxis. Let's see what we've got here. Okay. What are your priorities in this case? How would you stabilize? Yeah, stabilizing blood pressure is an act of doing the primary survey: airway, breathing, circulation. I would admit her to the resuscitation bay, call for senior help. Why do I not mention any of this? Okay. Okay, you need to treat this like you're in a hospital setting. So in the hospital setting, I would crap my pants, get senior help, put them in the resus bay, and then do primary survey while they're waiting. So ensure patency and be ready to intubate. So I could use a laryngeal mask, airway, or an endotracheal tube. Breathing, look for wet sounds, and then engage acute asthma management, which is under breathing, and circulation, which is heart rate cap refill. Do an ECG, and consider adrenaline. And consider adrenaline if they remain in shock, which makes sense. What's an MDI? I've seen this, don't remember. Just puffer. What does it stand for though? Metered dose inhaler. Why do we always have to use fancy words for medicine? MDI, 4 to 12 puffs, salbutamol, 100 mics via an MDI, and we use a spacer as well. Severe asthma, they're unable to breathe, they can walk and speak in one breath. So in one breath, they can walk and speak whole sentences. So you can ask them to speak. If they can't speak, it's a severe asthma attack on you. Okay. Start bronchodilator, consider anaphylaxis. Always consider anaphylaxis. Right? Unable to speak, visibly breathless, there's increased work of breathing, decreased oxygen sats, can't speak in sentences. So you do 4 to 12 puffs of salbutamol, 100 micrograms via a puffer, and you can wait 4 minutes and then repeat until you see improvement in symptoms in 12 puffs. And then you can also give them puffs of ipratropium bromide, 21 mics. Am I going to remember that? Hell no, not the dosage. And then you put them on a non-rebreather mask. Life threats, drowsy, collapsed. So there's the levels, right? Mild is when they can walk and speak in full sentences. Severe is when they can't speak in full sentences. And life-threatening is when they're drowsy and collapsed, aka we don't have that whole respiratory compensation with tachypnea and increased respiratory effort. It's very bad. And we use a continuous nebulization in that case, and we use ipratropium, and we start O2. And we assess the response in minutes. Let's see what they've said for asthma. Okay. Overview. Intrinsic causes: viral respiratory infection, irritants, pollen pollution, cold air, lack of compliance. Educate all patients with asthma to recognize early symptoms of deterioration, start reliever therapy according to the asthma action plan. Severity, rapid assessment, detailed ongoing management, intervention is topics not right for infants. Yeah. Asthma can't be diagnosed, yeah, that makes sense. It's a life-threatening condition. Acute shortness of breath and skin features, you consider anaphylaxis, jab them with adrenaline. Always forget this, but it's so important. Is it 1 milligram? Surely, right? How much adrenaline do we give him? Does anyone know? No. Adrenaline. Signs and symptoms: tingling, abdominal pain. I have that. One, two, three. 0.5 mg, right? What's a dosage? Oh my god, man. I have to just go to anaphylaxis, I guess. Mag self, adrenaline, 1 milligram per ml, 0.1 milligrams per kilogram, 0.1 milligrams per kilograms, up to 0.5 milligrams. Just give them 0.5 milligrams, man. Scary. 1 milligram per ml. 0.5 milligrams is half, so half a milligram of adrenaline. Okay, and what are we doing? Life-threatening, continuous hypertropium, we look for a response. If it's poor, we add mag self, and it has bronchodilator activity due to calcium influx that will associate with calcium influx. Within the hour, you start oral prednisolone and IV hydrocortisone, and then you continually reassess spirometry, pulse ox, and you're gonna get a life-threatening asthma case to do spirometry for you. It'll be quite hard if it's collapsed, exhausted, but if they should be improving, they look for dyspnea. If it's unresponsive to steroids, then you consider ipratropium bromide. But we just do salbutamol and ipratropium from the get-go. And we consider adrenaline if they're unresponsive. And peri-arrest, holy. I never have to see that in my life. Bronchodilator salbutamol plus ipratropium. Yeah, so you give them ipratropium and salbutamol, and if they worsen, then you add mag self. And additional treatment, if it's persistent, you give them adrenaline. And you can consider IV, and ventilatory support may be required. Non-invasive, who show no improvement with treatment, is starting to tire and show signs of respiratory failure. So if I see signs of respiratory failure, if I see that they're starting to tire, I'm going to start putting them in positive pressure ventilation. And corticosteroid therapy. At least in the first hour, or you can give prednisone. I'm not going to remember the dosages. Should probably do this. Okay. So, what are my priorities? Primary survey. Salbutamol plus ipratropium. Severe asthma. Tropium. Oh man, these dosages. Who knows? ETG, what are you saying? 10 milligrams. That's for life-threatening asthma. 10 milligrams. What about acute asthma? I mentioned that. Assessing the severity, treatment of severe acute asthma. I'm gonna give salbutamol 100 mics. Every 20 minutes or so for the first hour. 6 puffs. 1 at a time, 4 breaths. Okay, and give them 4 puffs, and you can repeat 20 minutes as required. Okay, salbutamol. So we'll just say severe asthma. This is life-threatening asthma. The patient will die if they don't get their treatment. So we'll say this is salbutamol, and I'll add ipratropium underneath. For salbutamol, be very specific. They need 100 mics. 100 mics, and we're going to use the technique is going to be 4 puffs with 4 breaths a puff per puff, and then wait and repeat 20 minutes as PRN. So severe asthma is when they cannot speak in full words. And life-threatening asthma. So we'll see, what else do we need? Ipratropium, and that's it. Bronchodilator therapy. That's all they need, I guess. Ipratropium, 500 mics. Milligrams. It is 21 mics, and then 8 actuations, 1 at a time. Ipratropium bromide. Oh, you know what? I'll remember it. 21 mics, and you give them 4 puffs. Or 8 puffs. Yeah, it's an actuation. Actuation meaning asthma. Doctor didn't teach me this. He meters 3 parts to a canister, metering wheel, an actuator, or a mouthpiece. Allow the patient to operate the inhaler. So canister is a metering valve and an actuator. I've seen these. Canister. No, not this. Canister. Strap. What? Okay, whatever. 8 actuations. Using the needed dose inhaler plus spacer. Puffer and a spacer. And then ipratropium bromide, 21 mics. You give via 8 puffs. So much. More frequently. Okay, so for severe asthma, we are looking at giving the patient a hunt. So the main treatment for severe asthma, where a patient cannot walk or speak in full words, is the use of beta-adrenergic agonist pharmacological therapy, including salbutamol. And this will be given via a metered dose inhaler with a spacer, and we will be providing. I'm done. I can use this too. So 100 mics via a metered dose inhaler with a spacer, and we'll be providing 4 puffs and 4 breaths per puff, and repeating every 20 minutes or so for the first hour, or more frequently based on the patient's responsiveness. And we would also consider ipratropium bromide. We would do 8 actuations, which is squeezes, 4 puffs or actuations. Call it actuations, you know what? We'll be fancy today. 4 actuations. 4 actuations. And this is 8 puffs, so 8 actuations. And that's it for severe asthma. And then for life-threatening asthma, we're going to change our treatment. Make this tomorrow. And if it's life-threatening, what do we do for life-threatening asthma? Asthma. If it's life-threatening, we would use same thing. Salbutamol, but we'll be using it via continuous infusion. And how much would we be giving? I think, is it 10 milligrams? Can't change it that much. There we go, continuous nebulization. 10 milligrams. We went from 100 mics to 10 milligrams via continuous nebulization. And so we can give ipratropium bromide. It's 21 mics. Now it's going to be 500 mics. So we can give quite a lot. Ipratropium bromide. Bromide, 500 mics. 500 mics. Continuous nebulization. No. Yeah. Added to nebulized solution every 20 minutes the first hour. And then if there is nil improvement, then we would consider number 1 using we said ipratropium, but now we need to consider using Magself, which is known to cause calcium influx and bronchodilator. Magnesium sulfate, that's going to cause calcium influx and bronchodilation. Okay. IV Magself, 10 millimoles. I can remember that. And then additionally, if the patient's unresponsive and they cannot inhale bronchodilators, or they're considered to be peri-arrest, then you give them adrenaline 1 mg per ml. How easy is that? 1 mg per ml up to 0.5 mg, because that's what we give a patient who has anaphylaxis. So if in peri-arrest or cannot inhale, then we can add on adrenaline 1 milligram per ml up to 0.5 milligrams. And then IV salbutamol, IV aminophylline, nebulization. If it's life-threatening acute asthma, you consider, harms of aminophylline outweigh its benefits. For life-threatening asthma is given aminophylline. You need to seek expert advice before giving that. Aminophylline. What the heck does? Mechanism of action. It's adjunct. Mechanism. It's a complex of theophylline and ethylene diamine. So it's ethene diamine and theophylline gives you aminophylline. And it relieves bronchial spasms. But what is it? What's a class of medications of aminophylline? This is where Wikipedia knows more. So bronchodilator. It's a non-selective adenosine antagonist. That's why I always link it to caffeine, because adenosine is inhibited or antagonized by caffeine. There's also an adenosine antagonist. Aminophylline is a non-selective adenosine antagonist. Okay. Adrenaline. Peri-arrest. Adrenaline, and you can consider aminophylline. And how does that work? It is a non-selective adenosine antagonist. I wonder if it has effects on sleep. You should be able to pass a blood-brain barrier then. So that's how you treat life-threatening asthma. Alright. So, what about mild? Just 4 to 12 puffs. Okay, so we'll say mild. Speaks 4 sentences. And then you just give them salbutamol. And we're going to give them 4 puffs or actuations of, no, we'll give them 100 mics as 4 puffs. And we're going to add 4 breaths per puff every 20 minutes for the first hour. Okay, that's how that works. Okay, so if I have to repeat, the pharmacological management of asthma depends on its severity. In mild asthma, patients can walk and speak in a single breath. In this case, we would manage it using a metered dose inhaler connected to a spacer that will be delivering salbutamol at 100 micrograms with 4 actuations of puffs and 4 breaths, each puff for every 20 minutes for the first hour. In patients with severe asthma, they will have difficulty speaking and walking in a single breath, and they may not be able to complete full sentences, and there will be evidence of tachypnea and increased work of breathing, which is in all. It's going to be significantly increased work of breathing. And in these patients, we would consider both salbutamol in the exact same above dosage, in addition to ipratropium bromide, which is a muscarinic agonist. And this is to further relax the bronchial smooth muscle. And it will be given at a dose of 21 micrograms, 8 actuations of puffs and 4 breaths per puff, and repeated every 20 minutes or so. Life-threatening asthma is accompanied by evidence of hemodynamic instability and significant decrease in the work of breathing and lack of compensation through respiratory drive. So these may be patients who are decreasing in GCS, have a silent chest, as seen in this patient. In this cohort, we would consider both salbutamol, nebulized, and we can consider a continuous infusion of 10 milligrams salbutamol. We can also consider using ipratropium bromide at 500 micrograms added to the nebulized solution every 20 minutes. And in patients who are refractive to this therapy, we would add on Magself at 10 millimoles. And in addition to this, we would consider adrenaline if the patient is peri-arrest at 0.1 milligram per ml and a maximum dose of 0.5 milligrams. And also consider aminophylline, which is a non-selective adenosine antagonist comprised of, to mention this, the theophylline and ethylene diamine. I will never remember that again, but that was pretty good memory. Oh, so that's the pharmacotherapy for acute asthma. And you want to also mention that you're going to do the whole rhesus pathway with A's, which includes your airway. You may consider positive pressure ventilation. Intubations in patients who are refractive to medical therapy and are exhibiting signs of respiratory failure, such as type 2 respiratory failure, which is hypercapnia and hypoxia. Let's see what else we've got. This is pretty good. I might add this to my notes. Thank you. Thank you, Key. You're a lifesaver. Absolute lifesaver. Okay, so I've got that. Let's paste this. Selective. Control V. Okay, next slide. What are clinical indications for ventilations? We said inadequate oxygenation. You do right. Is that just low SpO2, inadequate ventilation, respiratory rate, oxygenation, inability to protect the airway, GCS 8, intubate. Patient presentation, if they're refractive to medical therapy, is inadequate oxygenation and inadequate ventilation. Respirate is greater than 25, okay, 30. If it's PaCO2 is greater than 50 millimeters per mercury, PO2 is less than 50 millimeters of mercury, and SpO2 is less than 90. So those are your red flags. So when would you consider ventilation? Ventilation would be considered when the patient is not responsive or exhibiting signs of clinical improvement with the use of medical therapy alone. The patient would also exhibit signs of inadequate oxygenation, inadequate ventilation, and there also may be hypoxia and hypercapnia. And red flags would be arterial oxygen concentration less than 50 millimeters of mercury and arterial carbon dioxide concentration that is greater than 50 millimeters of mercury. And red flags would include respiratory rate that's elevated, decreased SpO2, and a GCS less than 8, as that requires immediate intubation as the patient cannot protect their airway. It's a good answer. I could say it in the exams. So what are the features of shock? Okay. Shock is a systemic state of hypoperfusion, may be defined into cardiogenic, distributive, obstructive, and hypovolemic shock. It may be accompanied by changes to the temperature of the peripheries, most often a decreased temperature, and there may be other system signs, and this may include an elevated jugular venous pressure. And there may also be respiratory evidence, and clinically we would observe hypotension, reflex tachycardia to maintain cardiac output. What else we got? Cold, clammy, cyanotic. Oh, I'm getting mad tired. How much time we got now? Study sesh. Where's the time? 24 minutes. Alright, let's do this. Finish off this case. Tachycardia. Yep. What are the features of shock? Hypertension. I should mention that way earlier. Less than 90 systolic and a mean arterial pressure less than 65. Right. Globally, systemic hyperperfusion that's insufficient to meet the metabolic demands of the body. It sounds like heart failure. Decreased cardiac output that cannot meet the metabolic demands of the body. Shock, state of systemic hypoperfusion which cannot meet the body's metabolic demands. Tachycardia is an early onset sign. Tachypnea, it's compensatory. There's cold, clammy, cyanotic skin. Can be peripherally warm. It's usually cold unless it's warm in distributive shock. Lactic acidosis. Haunted mental status. Cool. Cool beans. Next. What are some triggers for asthma? So, Rami has said intrinsic environmental pharmacotherapy. Very smart. Intrinsic is other pre-existing diseases of the respiratory parenchyma. This may include infections such as pneumonia, emboli such as a pulmonary embolus, other overlaying existing conditions such as fibrosis, bronchiectasis, and COPD. Environmental causes of asthma attacks may include cold air, pollen can cause thunderstorm asthma, pollutants, cigarette smoke, and pharmacotherapy that can increase asthma risk may include your beta agonists, such as your beta blockers, so your antihypertensives, and NSAIDs. We got NSAIDs and aspirin, which is cyclooxygenase inhibitor. Stress as well. Without smoking. So if I had to repeat that, triggers for asthma may be divided into intrinsic, environmental, and medication related. Intrinsic cause of asthma attacks. I'm going to the next slide to test myself. Okay. Intrinsic causes of asthma attacks include superimposed existing infections such as pneumonia, pulmonary embolus, for example, overlying COPD, and environmental causes include exercise, seasons, so cold, and then environmental stress, and then medications include NSAIDs, beta blockers, and aspirin, because we like to think it's its own thing. Aspirin's a COX. It's non-selective and it acetylizes COX. So it is an NSAID. What are we talking about? Vitals, pulse ox, sputum MCS. Look at effective causes, which I completely missed. If it's a respiratory case, do it. Sputum MCS. Do an ABG. Come on, I forgot. So much. Full blood count, EUCs, PRP. I'd refer to the Wells criteria, and if negative, I'd refer to the P roulette criteria and consider ordering maybe a D dimer. And IgE levels are elevated in atopic individuals. An imaging chest X-ray, and spirometry, which is diagnostic. FEV1. What's a formal name for FEV1? Forced expiratory volume over forced vital capacity. Forced expiratory volume over forced vital capacity. Oh. Oh, damn, tired today. Still grinding. cable's still working. Well, we've got 18 minutes left. Let's do this. Okay. So, how does asthma cause type 2 respiratory failure? There's hypoxemia and hypercapnia. Hypoxemia is in the arteries, hypoxia is just low SpO2. And it indicates type 2 respiratory failure. There is also respiratory acidosis. Indicating a type 2 respiratory failure, there's respiratory acidosis. Respiratory drive should be increased, leading to a hypocapnia. It's a prolonged period of asthma and the patient has become exhausted, and that leads to decreased alveolar ventilation and hypocapnia. Okay, so let's start with this. What test would you order in a patient with asthma? My diagnostic test for a patient with asthma is that of spirometry, in which I would assess the forced expiratory volume and forced vital capacity and observe for a obstructive pattern of respiration, where the FER, or the forced expiratory ratio, is less than 70%, I believe. Check again. What's the low FER? Spirometry. Just tell me the number. Come on, man. Normal is greater than 71%. So 70 or less is not good. Makes sense. Okay, what else? Okay, bedside investigations may include ECG to assess for evidence of a pulmonary embolus. I may then proceed to ordering full blood count CRP, looking for an infective picture, and other lab investigations could include EUC to assess the renal function following shock, any tubular necrosis, for example. I would also like to do microbiology investigations, including a sputum culture to assess for the causative agent, if it's an infective cause or exacerbation. And I would like to also do a ABG, looking for evidence of acidosis, hypoxemia, and hypercapnia, consistent with type 1 and 2 respiratory failures. Imaging may include chest X-ray to rule out life threats such as pulmonary embolus. So the thing I forgot the first time is, number one, I forgot microbiology, so sputum culture, and number two, in a patient with rest pathology, you do an ABG. You can't forget an ABG. What's going on, man? Okay, how do the kidneys compensate for acidosis? Generate new bicarbonate to replenish the bicarbonate buffering. Carbonic anhydrase converts into lumen by sodium hydrogen exchange. How do the kidneys compensate for acidosis? Carbonic anhydrase. Sodium hydrogen exchange. How do the kidneys compensate for an acidosis? The kidney contains carbonic anhydrase receptors, an enzyme, The kidneys contain carbonyl anhydrase, an enzyme responsible for combining carbon dioxide and water to form carbonic acid, which will then ionize to form hydrogen carbonate and the hydrogen ion. The hydrogen ion is secreted into the kidney via the sodium hydrogen exchanger, and the bicarbonate is reabsorbed into the vasculature to compensate for acidosis. So, what did I forget? Carbonic anhydrase. And I'm so tired. We gotta get this done. I'm gonna smash this case. Alright. Sodium hydrogen exchanger will reabsorb the hydrogen into the bloodstream. To the kidney, and the bicarb comes back out. And we will also bind the hydrogen ions to ammonia to form ammonium, which will then be excreted, or it can also be bound to hydratable acids such as phosphoric acid. I've already gone through that. There's exhaustion, cyanosis, absent breath sounds, CO2, can walk and speak in one breath, increased work of breathing, accessory muscles, walk and speak, so accessory muscle use. Okay. Bedsides, we mentioned that, ABG. How did I forget a pulse ox? Well, obviously in the hospital I wouldn't forget. Come on, an asthmatic patient not connect to pulse ox is ridiculous. You do an ABG, you got to do an MCS, and you got to connect them to a pulse oximeter. Okay. Next. So chest X-ray. Yep. Why do they have type 2 respiratory failure? It's due to decompensation, as the increased respiratory drive has likely decreased in the setting of chronic asthma attack. In the late setting of an acute attack. Said that generates new bicarb by carbonic anhydrase, and that gets reabsorbed. Whereas the hydrogen gets pumped out by the sodium hydrogen exchanger. I need more slides. Oh Lord. What are long-term management of asthma? Increase quality of life, reduce complications. Improve quality of life, reduce complications, and permanence. So we can avoid triggers, we can minimize the symptoms, we can maximize lung function and minimize side effects, and then we can... This is such a fluffy slide. Still working. Okay. Minimize symptoms, maximize function. Okay, so you can minimize the symptoms, you can maximize patient function of the lungs, and you can minimize complications. You can minimize symptoms by education, avoidance of irritants, you encourage exercise. So the priority goals in the management of asthma are to minimize symptoms, improve lung function, and reduce complications. To minimize symptoms and improve lung function, we include patient counseling on how to avoid triggers, what to do in the setting of an asthma attack, and then reducing complications also involves a treatment protocol and pharmacological and non-pharmacological therapies. So what's the long-term management? So start with PRN, and then we can add a low dose in corticosteroid, and we can increase corticosteroid dose to a medium dose, or you can continue low dose and add a LABA. And then you can continue the ICS and add a LABA, or increase to high ICS while continuing. So keep the ICS and add a LABA. The specialist step in 1 to 3 months of poor control. What is poor control? Symptoms 1-3 times a week. And step down if there's 2 to 3 months of good control. So if there's 3 months of good control, I'll step down. 3 months of bad control, I'll step up. Okay, long-term management of asthma involves the use of a beta agonist such as salbutamol. And we use a short-acting beta agonist initially for management of attacks. If this first-line therapy is ineffective, we may also consider adding a low-dose glucocorticoid such as prednisone to reduce inflammation of the lungs. If this does not work, we can either consider adding a LABA or increasing the dose of the glucocorticoids. And if this doesn't work, we may consider increasing the corticosteroid dosage whilst adding a LABA. And if this doesn't work, specialist referral. And usually give them they need to have less than 3 episodes a week. So SABA, and ICS, increase ICS dose, add a LABA, increase the ICS dose and add a LABA, and specialist referral. So reliever is your prevents bronchoconstriction, reduces inflammation. It's more long term. Then we can do ICS and LABA, or we can increase the ICS, and then we can higher dose preventer. Overview of various agents. There's beta agonists, xanthines. When have I seeps? So xanthines, and then there's your muscarinic antagonists. There are symptom controllers, LABAs, which reduce symptoms, anti-inflammatories, your sodium chromoglicate. I've completely forgot that. Sodium chromoglicate, leukotriene receptor antagonists, glucocorticoids, muscarinic receptor antagonists, xanthines, and asthma. Completely forgot xanthines. Theophylline is your xanthine. Okay, so the question is, what are the various agents in the management of asthma? The various agents for the management of asthma can be broken down into agents that will dilate the bronchi, agents that will reduce inflammation, and agents that will act via other external pathways. Your beta adrenergic agonists such as salbutamol or salmeterol, which is your long-term beta agonist, are used to bronchodilate the airways. Ipratropium bromide, which is a muscarinic antagonist. I've been saying it all wrong. So we get constriction of the bronchi and rest because they don't need it to be dilated, which makes sense. So your muscarinic antagonists include your ipratropium bromide. And xanthines such as theophylline and aminophylline are also, which are non-selective ADP, adenosine antagonists, are also dilators.